Thanks for coming into Toronto. It's actually kind of a labor of love. This is a great city. And I know it's a great city because one of my children married somebody from Toronto, so I get to come here more than I had before. Daniel told a little fib earlier. He said I'm the chorus leader. I'm actually not. It's Yoda sitting next to me, who's a Mayo-trained neurosurgeon for 25 years. He's kind of the guru of ProScan. Whenever anything is gravely wrong, all the young'uns, including myself, by the way, I think I'm a month younger, we all go to Yoda. So Dr. Shupak is an extraordinarily accomplished human being, both personally and professionally. Someone that I've looked up to for the last 10 years. We worked together for 10 years, and it's gone like that. One of the magics of this course, the magic of the course, because you can hear about radiology in all kinds of places, is the intense experience that we've had, but also in the neuro section, it's the clinical insight and actually instructing all of us, myself included, on what clinicians really want to know to perform what they need to do, which is why radiologists exist. You're here to serve physicians and patients, and probably in that order. And our job is to make physicians look good and get the right answer and get a great outcome. So without further ado, I'm going to give you a very quick, I'm going to try and make it very quick, overview, because you're at all levels. We have residents, fellows, intermediate level, and even some expert level people here to hear about MR. And to get to expert level, it probably takes, in a section, probably takes about 6 months of doing MR only. And with an instructor that you're willing to submit to and listen to and take their advice and not always be in a position to push back all the time. And this comes from a great book by George Leonard called Mastery. It's a book that you might want to give your children on how to master anything. But to become a master at something, you have to just do it a long time. And I think literally to be a master at MRI, you've got to do about 100,000 cases. You've got to be able to use the proper language and verbiage. And that doesn't just include the scientific verbiage either. It's the verbiage of how to talk to a clinician. And you talk differently to a family doctor, to an orthopedic surgeon, to a neurosurgeon, to a hand surgeon. It just depends where on the ladder you're speaking. Because if you give classifications to a family doc that they've never heard of, you're going to get a phone call, they're going to find you condescending, and they're just not going to send cases to you anymore. There's also certain things that you do and don't say. For instance, in the States, if you're dealing with a workman's comp case, you can never use the word degenerative. Because even if the patient has an acute injury and you use the word degenerative, they will never get fairly treated. So these are things you learn over a period of time, and it literally takes about 100,000 cases to get to that point. And probably one other aspect of being a master is being able to generate a diagnosis and come up with a story. And it doesn't really matter how you tell the story, as long as it's professional and concise, and you come to a conclusion. Can't rule out this. I mean, that's just one of the most terrible expressions in all of radiology. I mean, you can't rule out that, Martians aren't going to come down from the sky. So you have to try and, there are cases that are going to be indeterminate. And you can say indeterminate, but here's the differential diagnosis from most to least likely. And then finally, speed. Speed, it sounds low class in a way, but it's really not, because to succeed in a job in private practice, you have to be able to read at a moderate pace. And what's a moderate pace? Most practices in the United States and Canada will want you to do about 35 to 40 minimum RVUs of MRI. And however that equates into CT and X-ray, of course, the RVU units are going to be smaller, and ultrasound, so be it. But if you're applying for a job and you can't read 35 to 40 a day, you're probably not going to last, all that long in the private setting. Now, in the academic setting, that's a different animal, and you're going to be doing other things like research and teaching, et cetera. In our practice, we do teach, We do videos, and we do noon conference for an hour or two, etc. So now let's move on to our lecture. All right. I was loath to do this because it takes up a little time away from actually clinical imaging, but I think it's important that we just have an overview and approach to neuro. And, symmetry always works. There are some parts of the brain that are not symmetric. For instance, the jugular bulb can be, they say 2 centimeters different in size, probably 3 centimeters is more like it. The petrous apices of the brain are variably aerated, one side yes, one side no. The dural venous sinuses are markedly asymmetric, one side usually more hypoplastic than the other. And the anterior superior sagittal sinus, as you go from, say, the mid-coronal plane forward, peters out. When you look at a brain, you don't think to look at the brain shape. It's true that you can't really gauge head size from an MRI accurately. Those are clinical measurements. But you can get a rough idea of whether there's, macrocephaly, microcephaly, and some of the other cephalies that we won't talk about today. The hallmark of MRI in neuro is the midline sagittal. And we're going to do some quick localization by gyrus. And then as we go through our course, we're going to talk about some of the more detailed anatomy. Otherwise, we would be here for 3 hours talking about cranial nerves, etc. But we are going to drill into them, especially the ones that are more important. When you are examining, especially when you're earlier on in your training or in your practice, you're not in the habit of examining every dural venous sinus. You're not in the habit of evaluating every arterial flow void. And that is embarrassing when, the carotid artery is occluded and you don't pick up on it. Now, that one usually is either asymptomatic because you have collaterals or it shows itself. But a young woman coming in with a headache and you miss dural venous sinus thrombosis, that is a potential catastrophe. You just can't miss it. We're also going to have specialized imaging like perfusion and diffusion and some parametric imaging that includes cerebral blood flow and cerebral blood volume and mean transit time and cores and penumbras that we will explain and talk about. When I am examining my brain MRI, just a standard brain MRI, I take certain steps. I evaluate the pituitary gland specifically. I go through the taste pathway, the visual pathway, the auditory pathway, and I do that in about 15 seconds, which means you have to memorize and learn those pathways. A very common mistake that people make, especially when they're on call, is they forget to evaluate ventricular size. Someone comes in with a subarachnoid hemorrhage and they forget to say that there is acute hydrocephalus. They also may forget to look at the old images and see that the brain ventricles have gotten bigger or smaller. They're slit-like. Or on MRI, there's too much pulsation, too little pulsation. Which ventricles are big? Are the cortices effaced or are they atrophic? What's sagging? Unfortunately, as you get older, everything starts to sag. But, when you're younger, not much sags. So, if the chiasm is sagging or the cerebellar tonsils are sagging, you should pay attention to that. And what's the status of the periventricular tissues? I'm going to start our discussion with neurodegenerative disease, and you're going to focus on several key areas. And that's going to allow you to winnow down neurodegenerative disease into maybe 2 or 3 disorders. And very often you'll be able to come up with the disorder, which is kind of surprising to many of you. There are about 20 neurodegenerative disorders, but really there's 5 that you're really focused on. And we're going to talk about what those 5 are, things like NPH and Alzheimer's and PICS and LBD, Lewy body dementia, and maybe Huntington's disease. Substantia nigra, the entorhinal cortex. Substantia nigra for Parkinson's disease, that's another one that I left out actually. Entorhinal cortex for Alzheimer's disease, frontal lobes for Pick's disease, the extrapyramidal system for all kinds of diseases like MSA, multisystem atrophy, and corticobasal degeneration, the cerebellum for MSA and for PSP, progressive supranuclear palsy, the hemisphere invermis for pontocerebellar degeneration and for Kennedy syndrome, the collicular plate for PSP, and the brainstem and the hummingbird side and big panda shine, which we will talk about. What you can't miss when you're on call. You cannot miss, whether it's CT or MR. We're going to be showing you some CT. You can't miss acute hydrocephalus. You're scrolling around looking for acute stuff, infarcts, tumors, herniations, and you forget to comment on the status of the ventricles. I know this because, I've seen it in trainees all the time. You've got to know all the herniation types, including upward herniation, downward herniation, subfalcine, uncal herniation, and so on. When you're on call, if you've got a supratentorial metastases, it's not usually a medical emergency. But if they're in the posterior fossa, in fact, anything acute in the posterior fossa, the hairs on your neck should stand up. It's a small space. That's when people die. People with acute infarcts with swelling, people with metastases that are enlarging even just a little bit because the space is tight. You've got to be really on your game. Dural venous sinus thrombosis, probably the most important, commonly missed young person disorder. Acute stroke, that one, not so hard to miss. But sometimes if you're doing CT, you got to window and level pretty tightly in the acute setting. Bleeds, pretty easy, unless you're dealing with MRI and you're not that experienced an MR practitioner, but on CT, it's one of the first things you learn in residency, and we're going to talk about hemorrhage as it relates to stroke. Aneurysms, hard to miss these days, but if you miss it, it's usually not only a medical catastrophe, it's a medical legal catastrophe. And when I'm looking at my scan, especially MRI, I check the flavoid at the ACOM, the PCOM, and the carotid terminus, and I make a mental effort to deliberately do it. And then fractures, of course. If you're looking at a spine, most spine abnormalities are not an emergency, but we're going to show you some that are commonly missed. We're going to show you things that are unstable. But one thing that is an emergency is when you have a spinal block. And, a spinal block is when you have no CSF at the level of the abnormality and the cord is completely choked and compressed. There are a few real critical things also in the CT realm when you're on call that you just can't overlook. For instance, if you've got a bleed and you have a spot sign, in other words, you're kind of spouting blood right in the middle of that bleed, bad things are going to happen really quickly. You've got to mobilize. The swirl sign, this looks a little bit like a chronic subdural, but it's not. Chronic subdurals calcify, they're pretty heterogeneous. But actually what you're seeing here is swirling blood in a hematoma, so in an extraaxial hematoma. So that's another one that is really urgent. Now, in terms of sequences, I don't think we really want to go through every single sequence today. And we used to use something called proton density imaging. We don't anymore. We do use T2 imaging, but really the workhorse of neuro MRI now is the FLAIR, the fluid suppression study. So I'm going to go through a few basic sequences. There are a few fancy ones on here, and they're here as a reference. They're also all on MRI online with all the names from all the vendors. This is gradient echo inversion recovery. It can be done 2D or 3D. Here is a 3D gradient echo inversion recovery. It's often used to highlight with more intensity the gray-white matter junction. I'm going to skip over this one. This is a really important one. This is a gradient echo, a newer gradient echo called additive gradient echo, or ADAGE, MERGE, MEDIC, or MFFE. This is a workhorse sequence for spine imaging, especially in the axial projection. It gives you probably the best CSF to cord interface, and we're going to talk more about that. T1 FLAIR. Don't use a tremendous amount of T1 FLAIR, but some people use it for metastatic disease detection. It is another sequence that does better than simple T1 in highlighting gray and white matter junction. But here's your workhorse sequence. Here's your FLAIR. This is how you're going to look for white matter disease, tumors, I mean all kinds of pathology. This patient has MS, but that's not why I'm showing it to you. You can do FLAIR 2D or 3D. This is an axial acquisition 3D, and then it's reconstructed into the sagittal projection. So I can see a time when screening MRI for, say, a headache would be just simply an axial high-resolution FLAIR and then reconstructed, and maybe an MRA to rule out aneurysm, and you're done. Diffusion imaging. I'm going to skip over the discussion of diffusion kurtosis, which is just a measure of the heterogeneity of diffusion characteristics of any abnormality. And basically, kurtosis, when there's more heterogeneity, usually you have a more serious abnormality. And I'm going to skip over diffusion tensor imaging today for now. We'll probably show you some examples of it and go to some more mainstream sequences that are essential to your practice, whether you're a generalist, a neuroradiologist, and so on. So let's talk about BSI, blood-sensitive imaging. Some of you know it as SWAN, SWI, or Venus Bold. It's basically a 3D T2 star sequence, and it's there to find blood and iron and calcium. And it can also be paired with something called phase-sensitive or in-phase, out-of-phase imaging. But here's an example of a simple FLAIR, a T2, and then you see the blood-sensitive image. And it can be really valuable in neurodegenerative disease, which we're going to talk about because it has uber sensitivity to the distribution of brain iron, which you see in the globus pallidus and putamen. So you probably shouldn't be doing brain MRI now, other than say, well, you probably shouldn't be doing brain MRI now without some form of blood or calcium or iron sensitive sequence. Some of you may be still scanning with low field, as I am. You know, we read off of about 500 locations, other people's scanners, and we like to have a gradient echo if we can't get a blood sensitive sequence. And it's pretty blood sensitive, not quite as good as SWAN or SWI, but still pretty good to pick up cavernomas and most hemorrhages and most siderotic abnormalities. Here's an example of a cavernoma with some peripheral siderosis on a T2. Here it is on the BSI image. You can see it looks like popcorn, but so much more iron products are seen on this sequence. And here is the pathology from this patient. Here's an example of BSI, and I'm hammering on it because it is so important. Here's what's known as the swallowtail sign. There's the tail of the swallow right there. There's the swallow. There's the diagram of the swallow. Here it is magnified. And this is one of the signs of Parkinson's disease, and we'll see later on another sign is when the red nucleus iron and the substantia nigra iron bleed together, and there's no space in between. I'm going to skip over this right now. I'm going to skip over phase-sensitive imaging, and I'm going to go to cysternography. So MR cysternography, which is a wonderful test because the other kind of cysternography is just butt ugly. You know, you inject somebody with a radionucleotide, and you may put some pledgets in their nose, and you turn them upside down, and it's environmentally unfriendly, it's patient unfriendly, and if you can figure out where a CSF leak is by doing super, uber, high-resolution imaging with half-millimeter cuts with very water-weighted sequences in the right projection, and you can do that in the spine or the brain, that's how you get a cysternogram. And if you've got the resolution, you really don't need contrast-enhanced MRI to pick up an intracanalicular schwannoma. The resolution is so good, you've got such good CSF to solid tissue contrast that you see these really well. So why do we give contrast right now if we've got this available? Habit, maybe medical legal pressure, but it really isn't necessary. And there are a number of ways to perform very cysternographic imaging. You can do it with gradient echo, or you can do it with 3D fast spin echo imaging, 1.2 down to about 0.5 millimeters right now. Perfusion imaging and diffusion imaging, I'm not going to talk a lot about right now, but perfusion imaging is basically first pass imaging. It'll allow you to quantify cerebral blood volume and cerebral blood flow. This is going to be a marker of your infarct core. This is going to be a rough marker of your penumbra, and CBV divided by CBF equals mean transit time, how long it takes for blood to get through the brain, which you see here is delayed on the left side due to a left-sided carotid issue. Diffusion I do want to spend some time on because it's relevant to everything we're going to discuss. For those of you that are here all 5 days, it's really relevant in prostate. It is not so relevant or less relevant in MSK. It is extremely relevant in neuro. So it's positive for stroke in the first 3 to 8 hours. It is less sensitive anywhere where you don't have white matter volume. So it's not that sensitive in the spine. It's not that sensitive in the brainstem. So when you're in the brainstem, you absolutely have to have very high resolution, small field of view, thin section imaging to pick up diffusion restriction. Otherwise, you're going to miss it. Now, what are the causes of diffusion restriction? This is one of the most important slides in the course because it helps you understand pathoanatomy and pathophysiology. So, disruption of the sodium-potassium ATPase pump. So basically, ischemia leading to infarction is the one you all know about. The fluid gets into the cell and can't get out. It gets stuck in the cell and basically can't move around. And we'll explain how diffusion works in a little bit. But basically, normally, the white matter repels water in your brain, so water is constantly moving, and that movement is direction sensitive. And we'll talk about the types of direction sensitivity, but we have to encode in all different directions to analyze this direction of flow. But when it gets trapped in the cell, it just doesn't move. So it shows up on the diffusion image as a very bright area, and we can also see this in severe bouts of hypoglycemia, status epilepticus, and in something called TGA, transient global amnesia, which I don't have on here. Dense cell packing or any stiff tissue. Remember when you were in histology and you had cells that had no cytoplasm? Well, that's lymphoma. That's small cell or oat cell carcinoma. That's squamous cell carcinoma. Those are tumors that diffusion restrict in a big way. Tissue vacuolization, CJD or Creutzfeldt-Jakob disease, heroin toxicity, demyelination with necrosis in the large myelin plaques, and diffuse axonal injury are the classic ones. And then anything with high protein or viscosity, could potentially simulate an infarct, although these are usually round, something like an abscess, an epidermoid, and hemorrhage. A hemorrhagic phenomenon can also produce diffusion restriction. Also, various blood products can hide diffusion restriction, and that's called the blackout sign, which you'll learn about. So here's a T2, here's a flare, and here is a diffusion-weighted image. The patient has had an anterior cerebral artery infarct. The age is kind of indeterminate until you go to the diffusion image, and you see that the large core of the diffusion is mostly in the back and only scant in the front. So it has a lot to offer. Now, I said I was going to spend a little more time on this just because it's so relevant to everything we're going to hear in the next 5 days. You can get a false negative diffusion if you're too early, if you're within the first, say, 30 minutes to an hour, or if you're too late. If you're at 3 to 5 days, the diffusion restriction may wane. You may get a blackout effect where everything's so dark from various types of blood products or calcium that you can't see it. And as we said, if you are white matter deficient, if you don't have a lot of white matter tracts, as in the brainstem or in the deep gray matter with deep lacunar infarctions, or in the spine, then you're going to miss the diffusion restriction that's present unless you have very, very tight, high resolution. The most common cause of a false positive diffusion is something called T2 shine through, but there are some technical causes. Maybe you have an older machine where you can't turn up the gradients high enough to get the proper B value for proper diffusion weighted imaging. And then you've heard about some of the other causes of false positivity in infarction, one of which is viscosity, another one is stiffness, and another one is necrosis as in, say, heroin toxicity. I'm going to skip over my discussion of arterial spin labeling, which you can hear on MRI online. And I just briefly want to talk about stroke for a minute, because we are going to be covering vascular today. You know, somebody comes into your practice, usually if they have an acute stroke, they're getting a CT and a CTA. And the reason is it's down in the ER, it's faster, it's easier to perform, the patient doesn't have to hold still for as long. But then if they are an anticoagulation candidate, and that has massively expanded now in the last 6 months. We used to say we don't anticoagulate people if they're beyond the 2 to 3 hour critical window. Well, now we know that people benefit from anticoagulation as long as 12 to 24 hours, and they certainly benefit clearly from the Dawn trial with thrombectomy for probably up to 24 hours. In fact, they stopped the trial because it was so much in favor of delayed thrombectomy, in patients, 6, 12, 18 hours after a stroke. So this is a rapidly evolving field, and MR is becoming more important for that reason. So it's not as time pressing, and therefore you have time to get the MRI now, and you need to get the MRI. So you get a T1, a T2, a flare, perfusion, diffusion, the analysis, cerebral blood flow, cerebral blood volume, mean transit time, and then you'll probably get an MRA of the head and neck. You may do it without contrast or dynamically with contrast. And this is showing you a stroke series. And you can see here's a flare. I don't have everything up here. I've got the parametric studies up here, cerebral blood flow, cerebral blood volume. You can see the transit time and the time to peak. In other words, the peak arrival of the contrast is delayed. That's why the color is a little bit different. The diffusion imaging shows diffusion restriction in the MCA territory. And then you can actually calculate the velocity of flow using a parametric map for each pixel. And you can see that the velocity of flow is reduced on this parametric ADC map. Therefore, the intensity is lower and the attenuated appearance of the right MCA. You're also going to want to comment on where the stroke is, because it's going to matter. Is it M1, M2, M3, M4, or whatever? How far distally is it? Because more proximal strokes, not only are they worse, not only is the mortality rate higher, but those are exactly the people that you want to anticoagulate. So that will influence the neurologist or neurosurgeon as to whether they're going to intervene or not. This is just some MRA, and that's going to be part of the examination. And also part of the stroke examination is going to be susceptibility weighted imaging, SWI, BSI, SWAN, whatever you want to call it, to make sure that you don't have a hemorrhage associated with your stroke. Spectroscopy, this may be one of our few chances to discuss it. I'm mostly going to focus on hydrogen spectroscopy, since most of you are not doing phosphorus. You can do spectroscopy in a small area, in a single or a scant group of voxels, or in multiple voxels. If you do it in multiple voxels, you'll have a spectroscopy profile for every single voxel. And that becomes more relevant when we talk about prostate. Now, lying, lazy, no good crooks collected my insurance. I'm not castigating insurance agents at all, but it is a good way to remember the critical peaks in MR spectroscopy. And I've got a few other peaks labeled for you here that are relevant in certain disease processes, like alanine in meningioma or taurine in medulloblastoma. But these are the main ones. Lipid and lactate down around 1.33, usually an indicator of something anaerobic or a really aggressive tumor. NAA is a cell neuron marker. We'll talk about glutamine and glutamate a little bit later. Creatine is going to be a baseline marker, but it'll be reduced in certain disease processes. Choline is a membrane marker and membrane carrier, so any damage to cell membranes of any kind, for any reason, is going to raise the choline levels. So one typical profile you'll see in a tumor, especially a very malignant tumor, is the NAA drops and the choline goes up. And then MI, myoinositol, is another carrier marker for the cell membrane that alters in certain neurodegenerative diseases. So I've got lipids here. Lipids will show up in necrosis and certain lipid-containing masses like craniopharyngioma, anything that has, cholesterol in it. And you might say, well, how does that happen? Well, sometimes you get saturated lipids from ruptured cytoplasmic vesicles. So you usually don't see lipid in any tumor that doesn't have some cytoplasm. So for instance, lymphoma doesn't have lipid in it. It's not going to have a lipid peak because, there's no lipid in a lymphoma cell. Lactate at 1.33, usually an indicator of hypoxemia, and hypoxemia can occur from stroke or it can occur in certain very nasty brain tumors. But you do get lactate elevation in some really weird scenarios, and one of these is pilocytic tumors, which are somewhat benign and often curable, yet they have a lactate peak. So the rules generally apply, but there are some exceptions you got to memorize. Alanine is a doublet. It shows up at about 1, 5, and 4. I won't go into the chemistry of it, but just remember, for those of you that might take CAQ and Neuro, that it is associated with meningioma due to partial oxidation of glutamine, and you do see it in some other tumors like central neurocytoma. Acetate and succinate found at 2 and 2.5. This is a product of anaerobic fermentation, and you see it in brain abscesses from glycolytic carboxylation. NAA, this is the stalwart of the spectroscopy at 2 parts per million. It's synthesized synthesized in the mitochondria. It actually elevates in one very unique tumor, the central neurocytoma, and it's also elevated in the hypothalamic hamartoma, which is neuronal dominant over the glial type of hamartoma. The glutamate and glutamine brothers, also known as GLX, they kind of have a broad smear from 2 to 2.5. They're not that helpful in most scenarios, except in oligo, and now they're not that helpful in oligo anymore because you're going to see that oligo is actually a diagnosis that we make chemically and genetically. We no longer really make it on MRI. And even the pathology itself, the gross pathology, is not diagnostic of an oligo. It's more of a chemical diagnosis now. Choline. This is a salient component of the Kennedy pathway. It is involved in the generation of phospholipids in the cell membrane. It participates with a carrier, which is MI. Choline is phosphorylated by choline kinase, and choline is going to be elevated in any cell membrane destructive process. Taurine at 3.25 and 3.5. It is an inhibitory neurotransmitter that activates GABA. It is classically seen in medulloblastoma and PNET. It's got a few weird exceptions. It's found in pituitary microadenomas and metastatic renal cell carcinoma. I'm not exactly sure how to explain that, so you might not want to ask me. MI. This is a quadruplet peak. It's an osmolyte found mostly in astrocytes, but it sits just outside the cell membrane. And in tumors, it's involved in osmoregulation and volume regulation. It's found in certain high-grade tumors. It's also found in increased concentrations in the cingulum in Alzheimer's disease. It decreases in tumor malignancy, and that's all I'm going to say about it now. Glycine. I put this in here because it is the unique metabolite for GBM, glioblastoma multiforme, as it relates to metastatic disease, and sometimes that's a differential diagnosis. So if you have glycine in your mass, it's not going to be a MET. Now, it's not specific for GBM as the only primary tumor, but it does assist in this differentiation. I'm going to skip over the discussion of Huntington's chorea and spectroscopy as a demo for a minute and just show you what you can do with spectroscopy. You can make maps of spectroscopy. In other words, this is a map of choline. So it's showing you where the most active cell membrane destruction is in this tumor, and why that might be valuable is that might help direct the biopsy to the area of greatest activity or greatest malignancy. And here you see a typical malignant peak of a large mass. The cell membrane marker, NAA, just above 2, is wiped out. It should be up here, taller than choline. The choline peak is really high. and it's higher than the creatine peak as its adjacent reference. And that's really all I want to demonstrate. Contrast-enhanced MRI. There are going to be two ways you can do contrast MRI. You can do it as equilibrium phase injection of gadolinium. You do your standard T1 or your 3D T1. It takes 1 to 7 minutes, and boom, you're done. The problem with that is it only reflects disruption of the blood-brain barrier in areas of the brain that have autochthonous blood supply. In other words, blood supply without a blood-brain barrier, like the pituitary or the area postrema or the pineal gland. They normally enhance. But sometimes you get tumors that don't disrupt the blood-brain barrier. For instance, GBMs, 50% of the time on equilibrium phase imaging, the enhancement is scant. So first pass imaging is a more specific indicator of lesion vascularity and therefore a more specific indicator of malignancy. It's also used, first pass imaging, dynamic imaging, also called DCE MRI, dynamic contrast enhanced MRI. It's also used for strokes, as we discussed before. So here's an example of a standard contrast enhanced MR showing you rim enhancement around the periphery. And not only are we looking for enhancement, we're going to look at the pattern of enhancement. Is it thin? Is it thinner on the non-peel or peel side, as in abscesses? Is it lumpy, bumpy? How lumpy, bumpy is it? You know, are the nodules large or small? Do you have a pilocytic tumor? Do you have a solid component? And if so, how big is it? Motion reduction, I'm going to skip over. It's just something that's included in every scanner. But I will say that when you use motion reduction, called propeller or radar, it decreases. This is something very important for you to know. In every part of the body, MSK, prostate, and neuro, it decreases the contrast resolution of the image. So the whites are not as white and the grays are not as gray, and this is something your vendor may not tell you. 3D fast-spin echo imaging, also known as ISO-FSE, cube, space, vista, lava. It's got all kinds of names that they give to various parts of the body for purposes of sales. But basically what you're trying to do is you're trying to do a T2 fast-spin echo image with uber-thin slices with 50% overlap so you can reconstruct in any plane, orthogonal or oblique or otherwise, even curved planes. So this is something you're going to use a lot. When I first started doing very thin slices, one of my fabulous spine interpreters, not Malcolm, my partner, but one of our colleagues, didn't like it. We went from 3 millimeters to 1 millimeter. He goes, I don't like it. I said, well, why not? He goes, you see too much. I said, well, isn't that the point? And it took him about, and a very experienced guy, it took him about a month to get used to it. And it will take you time to get used to these very thin sections. If you don't like them, you can reconstruct them just like CT in thicker slices if you wish. And you can take that and make an oblique out of it, so you can look at the foramen. You can make axials out of it. And you know, in some countries where you get paid $100 for an MRI, this may be what you have to do. T2 FSE, reconstruct for disc disease, and you're done. You're out of there in 6 or 7 minutes. And I can see the day coming very shortly when we are going to winnow down the number of sequences for all parts of the body. Me personally, I read a spine in 2 sequences. I read a knee MRI in 1 or 2 sequences. And you know, you'll want to get there someday because you'll probably be forced to. Additive gradient echo. We already said that this is a very special sequence, also known as MERGE for GE, MEDIC for Siemens, MFFE for Philips, and ADAGE for Hitachi. This is a very robust sequence. You're going to use it a lot in MSK, but the one place you're going to use it in neuro is you're going to use it in the spine. So you may do your FSE sagittal and your gradient echo in the axial projection because it does a very good job of differentiating hard and soft disc abnormalities. Finally, fat water separation. This is a technique where you require a fat plus water image and a fat minus water image, also called in-phase imaging and out-of-phase imaging. Then you add them together and you subtract them. So that's going to give you 4 images. In-phase, out-of-phase, fat image, water image. So in one felt swoop, you're getting some pretty interesting contrast resolution. So let's take a look at what it looks like. The names for it are Dixon, M. Dixon, Ideal, FAT-SEP. They all mean the same thing. And here we've got our fat image, our in phase, our out of phase, and our water almost flare-like image. You can see that the water actually is dark. You can actually do a different type of subtraction where you can make the water white. So there are two types of water imaging from in phase and out of phase imaging known as ideal, Dixon or M. Dixon. The rest of these are going to be very consistent, and they are used extensively for assessment of bone marrow. They're also used in abdominal imaging, and that will be a story for another day. Okay, let's look at a little brain anatomy, and I'm going to do this very quickly. I'm not going to go through the entire brain anatomy review that I usually do, because we want to get started and we'll sprinkle the anatomy in. So these are some thin sections. You can see that we've got 1 millimeter slice thickness, and blow it up a little bit just to make it a little easier to see. Now I'm sitting next to a neurosurgeon, so that's kind of intimidating when you're talking about neuroanatomy next to a Mayo-trained neurosurgeon who practiced for 25 years and is one of the best neuroimagers in the country. That's not a lot of fun, but I'll try it anyway. So we're going to start out and notice where we are sagittally. Look at the reference lines on the right. I hope you can see them. I think you can, the dotted line right there. And I'm going to start out, in the region of the lateral sylvian fissure, and it kind of looks like a caterpillar, right? Here's the anterior ramus. Here's the vertical ascending anterior ramus. There is the sylvian fissure. And here's the posterior ascending and posterior descending ramus, right? It looks like a centipede, courtesy of the description made years ago by Tommy Nadich, who gets full credit for approaching the anatomy in this fashion. So most people don't like to look at sagittals off the midline, unless you're him, a neurosurgeon who knows the anatomy like the back of his hand. But if you're a neuroradiologist, you have to. You have to really become familiar with the brain as the neurosurgeon sees the brain, or the neurologist sees the brain. So let's start over here in Broca's area. Brodmann 45 and and 44 and 45. This is Broca's area, and we've got the letter M. So this is the inferior frontal gyrus. We've got the pars orbitalis, the pars triangularis, and the pars opercularis. And then behind that, we've got this staircase descending sulcus right here, which is the precentral sulcus. Now, right above the inferior frontal gyrus is going to be the middle frontal gyrus, and it's a pretty big thing. There's the middle frontal gyrus, and sometimes it actually has two rows, but I'm going to come out of the middle frontal gyrus again and go right back to the precentral sulcus. That's pretty easy, right? Because once you identify the staircase descending precentral sulcus, you've got precentral gyrus, which is almost always bigger and thicker than postcentral gyrus. And between them, central sulcus of Rolando. And the central sulcus of Rolando almost never communicates with or touches the centipede. It never touches the sylvian fissure. This is called the subcentral gyrus below that. So then we've got the postcentral gyrus, which means we have a postcentral sulcus. And the postcentral sulcus is going to be the upswing of the intraparietal sulcus, which is going to make up the superior and inferior parietal lobules in a minute. So now we come around the sylvian fissure, and what are we in? We're in the supramarginal gyrus. If we come around the superior temporal sulcus, so this would be superior temporal gyrus, middle temporal gyrus, if we come around that, that would be the angular gyrus. So supramarginal gyrus plus angular gyrus, this whole area right here, inferior parietal lobule, which means if we go medial to that and up, superior parietal lobule. Superior lobule, inferior lobule. So this arcuate area right here, and this upswing of the postcentral sulcus marginates the inferior parietal lobule. So let's keep going now towards the midline. And let's go to the midline. We've got the brainstem, the inferior colliculus, the superior colliculus, the habenule and posterior commissure, pineal gland right there. And then we've got the massa intermedia, the fornix, and the lamina terminalis, the rostrum, the genu, the body, and the splenium of the corpus callosum. We're going to look at the optic chiasm to see how it sags or not, related to the pituitary gland. And we're going to look at the cerebellar tonsil and draw a line from the tip of the basion to the tip of the opistheon. And that's going to define the foramen magnum for us. And we're not going to make the diagnosis of Chiari malformation based on tonsillar position alone, ever. Because otherwise people are going to get operations that they don't need. So we come around here to the callosal sulcus in this indusium griseum right here. And then the next really most important sulcus is the cingulate sulcus. So let's follow the cingulate sulcus all the way around, and it ends right there as the pars marginalis. So cutting almost perpendicular to the pars marginalis is the central sulcus of Rolando. So the pars marginalis here in front of it, the paracentral lobule, and then behind that, the precuneus and the cuneus, the occipital lobe. So the parietal occipital sulcus separates the cuneus from the precuneus. And this H-shaped structure here, the subparietal sulcus. So now we've got the calcarine sulcus. Calcarine sulcus meets parietal occipital sulcus and continues on as the anterior calcarine sulcus. Just above that is the lingual gyrus, looks like a piece of beef tongue or cow tongue right there. And then we get into our posterior fossa and our cerebellum with the cerebellar vermis, the superior medullary velum, and the inferior velum. And these are important landmarks for certain disease processes, like, for instance, medulloblastoma. Now let's take our supramarginal gyrus, our pars marginalis right there, and let's locate it in the axial projection. Now what I'd like you to do is I'd like you to imagine that we have a clock face. We've got 12 o'clock, thank you. We've got 6 o'clock. And then I'd like you to take the widest biparietal diameter. And then I'd give that 9 o'clock and 3 o'clock. And this kind of works irregardless of whether you've angled orthogonally or whether you've angled obliquely. And now I'm going to take those away. And let's go back to the pars marginalis, because here's our central sulcus. There's our pars marginalis. And it makes like a little mustache when you're up high. When you're up high, it's a happy mustache. It's like Salvador Dali's mustache. When you get down low, the mustache starts to invert. So that's how you identify the pars marginalis. Now, why is that important? Because lightning striking into the pars marginalis, into this basket, is the central sulcus. And when you see this little knuckle along the central sulcus, you're in the hand motor area, hand sensory area. And this would be the paracentral lobule up here. If you get meningiomas over here, this will be the homunculus. This is where you may get foot weakness. But this is a real important landmark, this knuckle right here of the central sulcus. Now we said the post-central sulcus is the continuation of the intraparietal sulcus. Why is that important? Because the intraparietal sulcus should do this. It's not in this patient, but it should go all the way across like this from 3 o'clock to 5 o'clock. So this would be 5, this would be 3. They should connect, but they don't in this patient. And that would be your intraparietal sulcus. So what does that mean? That is separating for you inferior parietal lobule from superior parietal lobule. And it's there that I'll stop and we'll start looking at cases now.